Hi, yeah, it's North Wales here. Graham Thomas, Network GP, just chairing the select band we've got up here. Can hear you and see your slides. Fine, we're ready in North Wales.
Oh, yes. You're taking your seats now?
3,400 in 2016 and just over 4,000 in 2017. I think that's mirrored across Europe and in the US. So it's an increasing demand on this technology in terms of treating patients with symptomatic severe aortic stenosis. 61 per million population is the UK. This is the slide from 2016 and just shows us, so that's England, Northern Ireland, Scotland, and we're down at the bottom there. So we're doing half as much as Scotland and Northern Ireland in 2016. These figures obviously haven't been, Peter Ludman hasn't updated these figures yet for 2017, unfortunately, whereas he has for the rest of the 2017. So I'll show you that data in a minute. So Wales has the lowest rate of TAVI in the UK and lags behind the rest of the UK lags behind the rest of Europe in terms of TAVI provision, in a nutshell. So for us, these are the last 4-year data from 2015 through to 2018 as of the end of October. So you can see the total numbers, 31, 31, 50 last year in 2017, and 65 up to the end of October this year. You'll see the spread, so there was an increasing in blue, an increase in the acute patients. So urgent means that they were admitted somewhere else or to our institution and then done as an inpatient. So these are inpatient TAVIs after the acute presentation, be it with heart failure or an NSTEMI and so on. One salvage patient into 2016 that we did as a post-cardiac surgical patient. So you can see the numbers are increasing, 47 compared to 40 in terms of our elective service this year. So we're likely to be looking at something like 80 to 85 for the total year 2018.
47 and 19 is 66.
Oh, you do my maths now. I didn't try that.
That's all.
That's the first we can remember. I'll show you the baseline demographics in a little bit more detail, but two things. Same age group as roughly as the British standard, which is 81.5, whereas we're 80.76, the average age of the patients we're treating, and 40% of them are female. So that's where we sort of stand compared to the UK figures. This is for 2017 data now for BISUS. This is the age spread, so 57 between 80 and 90, and 9 nonagenarians. So 66 of them are over that's just in the last 22 months. Obviously some younger patients under 70, and they're directed to us specifically by our cardiothoracic surgeons because they're deemed high risk for surgery by some other means. Okay. Those patients, so 27% of our patients have previous some form of cardiac surgery, be that a new valve, so it's a valve-in-valve, or previous bypass surgery, which is higher than the UK average. 33% of our patients are diabetic, 10% more than the UK average, which suggests that they may be a little bit more complex in terms of other comorbidities, in terms of renal and cerebrovascular disease. And I'll just pick out a couple of things. Renal failure, 5% versus 1% in the UK data set. Astonishingly, 55 of our patients have COPD compared to percent versus 24% in BISUS. So we've had a few more, had previous MIs, 33 versus 22, and a few more, and 10% more AF in our aortic stenotic population as well. There's a whole raft of the general comorbidities. I'll just point out two things really. 20 of the patients with porcelain aortas, extensive calcification of ascending aorta, and another 5 who've had a previous balloon valvuloplasty. So they've had some point of balloon valvuloplasty in the last month or two, and then gone on to have a TAVI in a sort of stage fashion. 14 frail with mild to moderate frailty patients, which is a driver for our cardiac surgeons. So this is the mean logistic Euro score of patients in the UK that are treated with TAVI. It's currently 18.5 now, 2017. So it's pretty stable really at around 1918. This was 2016's data for Morriston on the right hand and the UHW on the left. So in 2016 we had the highest logistic Euro score of, or on average, of our TAVI patients in the UK, both centres. So we're doing higher risk patients than the rest of the UK. So 2017, there's a lot of high levels of risk factor missingness. What that means is to calculate the logistic Euroscore, you need a number of risk factors. So this is the UHW, so we've got over 90% of the risk factors in, so we're good. Obviously, 100's the best. Marston are down here, which is less good. But that's a data input issue. So what that means is that NICO can't calculate the logistic Euroscore for all centres in the UK. Because if your missing data is lower than 50%, they'll exclude you from just this slide. And that's where we are again. So we are the highest risk, doing the highest risk patients in the UK in terms of TAVI on those centres that have added enough data into the data set to calculate the logistic Euroscore in 2017. The mean is 22, ours is 38. Most of them are done transfemorally in the UK, some small numbers transfemoral surgical and transaortic, subclavians. If it's not done transfemorally, you see surgical cut-downs in the green are going down, so they're becoming less popular. Direct access subclavian is our alternate access of choice at the UHW. Dave will tell us about Marston. So we've done 110 transfemoral, 5 subclavians. We've used local anaesthetic for 90% of our cases, 10% GA. That fits in with the UK data, so 80% of cases were done under local anaesthetic in the UK data set in 2017 now. So this has gone almost uniformly in the UK to a local anaesthetic procedure. And that sort of inverted commas minimalist approach means it's transfemoral. Femoral is where you do it where possible. You have no lectin lines, you do local anesthesia. Analgesia and sedation is managed by expert cath lab staff, and without them buying into this, we wouldn't have been able to do that as smoothly as we've been able to. Ultrasound guided vascular access, better for your vascular access outcomes. You know exactly where you're sticking the femoral artery. No urinary catheters and facilitated recovery in CCU. That has an impact upon CITU bed stay because no one goes to CITU anymore, which has a massive impact certainly on the infrastructure. Straight to CCU, so occasionally that is a problem if we've had a lot of primaries because they're all going to the same beds. So we've had that issue on 1 or 2 occasions, but it's certainly decreased hospital stays by doing them under local anaesthesia. As anyone knows who's had a local anaesthetic procedure or general anaesthetic procedure, you recover quicker, particularly if you're 85 or 86, you get them quicker, whatever you've had done. It's cheaper in US cost models than surgical aortic valve disease by some considerable margin, and I'm sure it definitely is in our margin, although we've not calculated it per cost per case. It's something we should perhaps do. Major complications, we've had 2 major bleeds, 1 life-threatening bleed and 1 major vascular injury that required surgical repair and stent. Our major vascular complications are 2.6% across the 115 patients compared to 2.3% in the UK data set, which I think is equivalent. We've had no bailout PCI and 1 bailout valve in valve. That means the first valve is dislodged or gone too low and you put a second valve in. And we compared favorably to the UK with that 2.6% in hospital CVA. So I'd like to see this lower, and I think it's just the infirmity and the patients we're getting, the higher risk patients as a cohort. 10% more than the diabetics, for example. You're much more likely to get periprocedural in hospital CVAs, I think. And I've seen that in maybe 1 or 2 of our patients. Post-TAVI results, aortic regurgitation is a clear marker of quality of the valve that you've put in. So if you get moderate or severe aortic regurgitation, that's a bad outcome from your TAVI. In terms of it can have longer-term manifestations. So the inpatient echo, we've had 97% of us have had either mild or no aortic regurgitation and 2.6% moderate, which compares very favorably to the UK average. 8.7% of ours have needed a post-procedure permanent pacemaker compared to 16% for the Medtronic valve that we use in Cardiff. This excludes 10% of patients or 12% of patients who actually had a pre-procedure. So they've already come having got a permanent pacemaker in already. 3.4% is our in-hospital mortality compared against 2%. So that's a 1.4% percentage points higher. I think that really comes on to the risk of the patients that we're treating. Because when you look at it, of course, we're 16% higher than the national average in terms of the risk and the acuity of the patients that we're treating. There is now a 30-day mortality predictive model that you can put in on the BSIS data set now, and I haven't done it for all of these 115 patients, and I'm hopefully going to be a registrar project in the next couple of months, but you can individually put in all that data for each one of those patients, and then we could get perhaps a better risk-adjusted model of what our mortality should be at 30 days, rather than one by me saying we've got very high-risk patients and our mortality is 1% higher. And I suspect that will be much higher. But we'll see, we need to do that audit. Waiting times, we've got a couple of breaches for December that we have to treat. But if I'm honest, we've got no data on waiting times because we've got no waiting times for any of our targets for angiography, echo, outpatients. They're all being measured now, but the component waiting times are fast. We don't have them documented, and so we've got no idea where some of these patients are on their pathway by the time they get to us. So if I'm honest, they're waiting way too long for any procedure, but I can't quantify at the moment because I don't have the tools to do it. We need better processes across the board, I think. We're increasing our inpatient referrals. I think that could be done a bit quicker, if I'm honest. Having seen some of the patients that come across recently, but all the outpatient tests are pertinent to each health board. Echo waiting times, angio waiting times, CT, aorta waiting times. We're as bad as any of the other health boards in terms of the waiting times for some of these things. Waiting to see us in clinic, waiting for other tests, and MDT discussion. All that pathway can be, I think, improved at various points. And that's a job for 2019 to really get that waiting time down. And of course, funding the procedure is a crucial part of it, because the more of them we can do, the less, obviously, your waiting time is. So to summarize, we meet BCS, SCTS standards in terms of the service structure. The commissioning, we've had an agreement of where we are collectively of where we think the service should be. It just needs to be approved and then subsequently funded. They're perhaps the two most difficult things. So just to give you an example, we've got at least 15 that need treating before the end of the year. If I spend my time doing 15 forms for prior approval, that's a session and a half or 2 sessions of filling in a form that's already decided by our cardiac MDT that this patient should have TAVI, so it's approved by WISC. Personally, I find that ridiculous. I'll leave that there because I'll get worked up about it. The minimalist approach in the UK does facilitate early ambulation and discharge, and I think it's just allowed us to do more cases per day and improve the efficiency of our service and getting people home quicker. We've got under provision compared to the rest of the UK. We've got a large number of patients who are untreated at the moment, both in terms of on waiting lists and out there who I don't think are coming to see us, because there's certainly some health boards that refer much more than others. Successful valve appointment in 100% of cases. Our mortality, stroke, vascular complications are comparable to the national data, despite having a much higher risk profile. And there's a lot we can do to improve the whole system, I think, to improve the service for these patients. I suspect at Boston, but certainly for us in South East Wales. Thank you. That's it.
Just three quick logistic questions. Do you have an anaesthetist?
No anaesthetist in the room, which has important implications because, like most hospitals, have a real problem with ODPs as a national service issue of not enough ODPs. So that frees you up, and that would be a big improvement.
And then do you also have this concept of standby surgery or bailout for any cases where you have a whole theatre team empty where they could be perhaps in an
Have we got one of the roving mics? Because the North Wales people won't be able to hear you at all there.
Sorry.
Yes, so yes, Alex Chase from Morrison just asking Richard Anderson a few questions about Cardiff. He's clarified they don't have an anaesthetist in the room, and I've now asked him whether they ever have bailout cases or standby surgery cases where a whole theatre team is kept waiting, not doing anything, with the theatre empty in case there's a rare complication of TAVI.
The answer is no, because we
The
have one
answer's no.
case since 2010. We had one patient who needed, two patients, sorry, who needed urgent surgery. One needed urgent surgery, and then one needed immediate surgery. So only two. So that it seems little point if you'd leave a theatre on standby for a procedure that you've done for 8 years and used twice.
Okay, so 8 years used twice, there's little point. So you might be surprised to hear that we do have that category of patient where occasionally, again, it's incredibly rarely used, but they're deemed. And that does come from the commissioning policy, which is why I mention it, because there is a cohort of patients that, or most of them, are supposed to be commissioned on substitution basis. So they're high risk for surgery, but not turned down. And third question.
The question is then, do you keep your cath lab open for complex PCI cases?
Absolutely, and no, we don't.
Yeah.
As in, we don't keep a surgical theatre free. Third question is on pacing. Do you ever identify someone as high risk of AV block or whatever and put pacemakers in up front before the TAVI? Because otherwise you're doing twice as well as every other core valve centre, or is it just...
Well, we used to do that, actually. We used to do a lot more of that. I've gone away from doing that in the last year because you don't want to add one, because often you need to get the valve in, you need to get the patient treated quicker than, because otherwise, if it's an outpatient setting, you'll say, okay, well, let's put a pacemaker in. That's a month wait for most centres to do that. Then you'll say, oh, I wanted it to bed in for another month. And then that's 2 months down the line. You just put, so it's better to do it. And then if you need to put it in. So what really that pertains to people with right bundle branch block, and at least first degree heart block in that context. Because with the core valve technologies now, Evolute and the Pro, the pacing is lower. The pacing rates are lower with the new, because you can reposition them. Also higher implants give you lower pacing rates. We just do it and see whether we need a pacemaker and then get it done as an inpatient afterwards.
Straight away, or maybe the next day?
No, usually the day after.
Because
It depends on my
I think there's some, we've never put one in up front, but sometimes you wish you had, because of course with the local anaesthetic, and if you've got 50% of your people with COPD, the main benefit is to have them sat up and then out of bed as quick as possible. And if they've got a temporary pacing wire in the groin and have to sit overnight, so we're putting quite a lot of new work on our pacing colleagues, but I just wondered it might be better to put some in up front, and wondered what your experience was.
Well, a few years ago we did put one in straight after the case. Just somebody was ready to put pacemakers.
Yeah, we've had that. That's the gold. Really nice service.
Yeah.
Okay, we were planning to have a discussion at the end of after the two speakers have spoken, and we'll just take one more question.
Thanks very much, Richard. I enjoyed that. Great outcomes. Can I just ask, I mean, I know that the waiting time's a bit tricky and the workup can be complex, but do you have any information on event rates on the waiting list? So death, admission with heart failure and...
Well, I haven't got admissions with heart failure, although, I've got as Peter Cameron will tell you, I've got a board of which I've got, in my mind, I've got, severe patients that I know that, at the time of referral, they're really late into their presentation, so you have to get them done, in the next 2, 3, 4 weeks, and that's what I try and do. So I've got sort of a temporal list, and then I've got a risk management list, which is slightly different than my temporal list, and I have to pick and choose. And of course, we do get calls from, relatives saying, well, I'm getting worse, and we try and get them in the next day. We've had one death on the waiting list. There's a chap actually who I got through from start to finish as his planned admission was 4 weeks, in fact, and he died on the Saturday before he was admitted on the Sunday. And he was due to have his TAVI on the Tuesday, because I brought him in a bit earlier for that. So, that's upsetting. I have to say. So, yeah. But I have to say, you know, it's a whole system problem, a lot of these patients. It comes quite late into the game. I saw a guy today who's come a little bit later. He's gone into atrial fibrillation, and he's now got creatinine of 200 on the ward, who was actually referred by Liam 8 weeks ago. And he's you know, his renal function was normal 3 months ago. So, and he was in sinus with it. So you've changed, because, and it happens everywhere, Nigel, and it's no criticism for any specific hospital, but they're coming later into the game, and so they then give, I'm sure it's the case of Boston and us, they come later to the party. So they're a bit high risk.
I just sense that these are high risk patients, and we've got to do our bit to fully work them up and dot the I's and cross the T's, and do it, you know, in a swift way, because we know that symptomatic AS has probably one of the worst outcomes of any condition in cardiology.
And I get that all the time from now in Bevan. They all worked up exceedingly quickly, as quick as the system can, for sure. And I think the patients definitely appreciate that, and I do. Just we've got to get them done quicker.
Thank you.
Okay, so we're going to have the South West Wales experience now. Okay.
If I can have the slides up, thanks very much. For those of you who don't know me, I'm Dave Smith. I'm together with Alex Chase and the Cath Lab team and the wider team going to present to you the TAVI data for the two health boards of Abertawe, Bro Morgannwg and Haldar. So this is what I've been asked to present on, and I will. So I've been asked to just talk about referral pathways, MDT working, again, like Richard, the procedural complexity volume as well as the outcomes. And the last teaser I was given was constraints and challenges. So this is a little bit wordy, but essentially this slide describes the outpatient pathway for people entering the system. And similar to what Richard's described, what we now have is a non-working pointer, so I'll walk over. Hopefully, before we get to see these people, they'll had a number of diagnostic tests. Classically, a transthoracic echocardiogram to prove the presence of aortic stenosis, diagnostic coronary angiogram as well as ECG, chest X-ray, blood tests. Then they get seen by a cardiac surgeon first, then a cardiologist. Then we have an MDT discussion, and obviously we offer them one of three therapies, which is nothing, or as it's otherwise known, medical therapy. Rather a misnomer, because there is no medical therapy, obviously, for aortic stenosis. Conventional surgery, or they get offered TAVI. The next test they get is a CT, then they get a TAVI. So we've streamlined the workup we were just discussing with Nigel's comment over the years. We used to do TOEs, multiple tests, angiograms, etc. A gated CT is sufficient these days to tell us the state of the iliofemoral anatomy for access, the size of the valve, and any aortic or aortic annular pathology that will guide the procedure itself. I'll talk about the procedure a little bit later on itself. And as Richard's alluded to, we also have an inpatient pathway, because as you'll see, a large proportion of our workload has been in recent times inpatient people. Either they presented to us de novo, or because of long waits, which I'll also come on to later, they decompensated and become admitted to hospital, and we've then performed an inpatient procedure. So what does MDT working really look like? Well, we have a weekly TAVI clinic in which we have two TAVI cardiologists as well as a TAVI nurse specialist in clinic with us. In 2019, we're hoping to include the surgeon in that same clinic, but at the minute, the surgeon and the cardiology review is on a separate day, which clearly for these elderly patients in geographically remote areas can present problems. We have a weekly MDT, which consists of two TAVI cardiologists, cardiac surgeon, an imaging cardiologist and a TAVI nurse specialist. But usually what we'll also do, according to the specifics of the patient, we'll have a co-opted review by usually care of the elderly, but not exclusively, oncology, haematology quite frequently, anaesthetic, and as Richard's mentioned, a lot of these people, when they have lung disease, will get a respiratory clinician opinion as well. We would like to include the elderly care physician with an interest in frailty into our weekly MDT. That's work in progress currently. So the actual TAVI procedure, the same as Richard's described, we're now going to this so-called minimalist procedure. So we have default transfemoral arterial access, that's what we're aiming for, and we get that in at least 90% of patients. Local anaesthetic with some intravenous paracetamol, non-sedating excellent analgesia before we put the tubes in the groin arteries. Default guidance using ultrasound to get into both the arteries and the veins. We put a wire from one leg to the other in case we do anything naughty to the leg arteries. And these days we will pre-stretch the valve when we put the self-expanding valves in, but not the balloon expandable valves. I'll talk about that in a little bit. We guide the results of our procedure using a combination of a transthoracic echo, the hemodynamic monitoring, and the aortographic features of the valve itself. We close the hole we've made with what we call so-called plug-mediated closure devices to allow early ambulation and early discharge. And our default used to be, they used to go back to our cardiac short stay, but we've had to temporarily relocate them 4 hours on CITU just to bed pressures. Then they drop down to the ward 4 hours after the procedure, or up to 4 hours after the procedure. And we're aiming to discharge these patients within 48 hours of their TAVI procedure. So we use 2 valves in Morriston. We use the so-called balloon expandable valve, an inflated balloon to expand the valve prosthesis into the correct location, or we use the so-called self-expanding valve, which is a nitinol spring mechanism, if you like, which expands itself into place. So we use both of these technologies and we select them according to the clinical characteristics of the individual patients. So I'm just going to move on to talk about the sort of complexity of patients treated. And if I say one word to you, this is age dominated. What a great surprise. We can see from all these curves of series of epidemiological studies of valve disease. Valve disease is related to age, full stop. Over the age of 65, the incidence and prevalence of valvular heart disease exponentially increases. Why is that a problem for our population? And as the circle shows, this is why this is a problem for the Welsh population. We have double the volume of elderly patients compared to the UK norm. So this is the last census data from 2011. So over the age of 65, we have a relative increase compared to the rest of the UK in the elderly population. If you look at the over 85-year-old population, 11.7% of the whole Welsh population are over the age of 85. The UK norm is 5%. This is why age is particularly a problem in Wales. This was a bit of good news earlier this year from the BBC that Swansea actually got in the top 10 of something. So having been relegated from the Premiership, clearly in football, Swansea is in the top 5, but the oldest city in the UK. So if you look at this data that was commissioned by an agency, but essentially commissioned by the BBC, in 2016, 1 in 5 of the Swansea city population was over the age of 65 years of age. When you look at a comparison where you've got Bournemouth and Worthing on the table, you know you're in trouble, put it that way. So as you go west from Swansea, and north, to be fair, into mid and west and North Wales, the population age increases further. This was purely looking at cities. The other problem we have, which is also age-related in Wales, is clearly comorbidity. This is Public Health Wales data looking at comorbidity in the Welsh population. And again, you can see from the age of 45 onwards, you've got nearly half of the population are reporting 2 or more long-standing chronic illnesses. So we also serve a comorbid population. Age plus comorbidity is not good news when it comes to valvular heart disease. Richard shown you this is the surgical scoring system that we're currently commissioned by WESC. This was 2016. Richard's shown you 2017. That's where we sit. We were part of the missingness criteria, which I have raised with Peter Ludman. Our logistic Euroscore hasn't greatly changed over the 2 years, but again, we are above the UK norm. So I'll just talk now about the volumes, demographics, as well as the outcomes. So in 2017, we did 46 cases, mean age of 83 years. And you'll see in red, over half of these people were inpatients. And that really does represent a problem. 10 of the total cases, 22% were done under general anaesthetic. 6 of them were so-called non-transfemoral, if you like, a surgical TAVI, as opposed to 4 transfemoral cases were done under general anaesthetic. So this is for 2016. Our access here was predominantly percutaneous. We'd switched over at the start of first quarter of 2016. Just under 1 in 5 were surgical cut down, and 13% of them were transapical or transaortic, i.e. surgical TAVIs, because of usual peripheral vascular coronary disease. In 2016, we did 90% of our femoral TAVIs under local anaesthesia, 10% obviously under general anaesthesia. And back in 2016, we were about 2/3 to 1/3 dominated by the balloon expandable valve. And then if we move on to compare this to 2017 now, if we look at the outcomes for these people, so we actually failed to get 1 valve in transfemorally due to peripheral vascular disease. We had 1 procedural death, 3 post-operative strokes, and 5 new pacemakers. What I'll do, I'll come and show you this compared to the UK norms, which is done later on. These are the criteria we're meant to present to in terms of this so-called VARC, the Valve Academic Research Criterion. We had 1 patient die within 30 days and 3 patients who had moderate leakage around the valve. No patients had a severely leaky valve. If we come up to date to 2018, this takes us up to the start at the end of last week. We've done 80 cases so far this year, similar mean age, 82.7 years, half of them are male. The inpatient rate has dropped, but it's still 40% of our patients are inpatients, and all 80 of them are done transfemorally. We've done 1 case under general anaesthetic for a surgical cut down. So our femoral access has increased to 99%, amazingly clever maths. Valve type is virtually split down the middle now. So half our patients get a balloon expandable valve, half our patients get a self-expanding valve. The slide clicks forward. And again, our local anaesthetic rate has increased yet further from 90 to 99%, with just the 1 case done under general anaesthesia. Richard's already shown you this is replicated across the UK. This is the BSIS data for 2017. Across the UK, 4 out of every 5 TAVIs are done under local anaesthetic. What about the outcomes for 2018? So we've managed to get all the valves in the right place thus far. We've had 1 naughty valve that decided to slide off into the aorta, and we had to put another one in. We've not had any procedural deaths this year. 2 strokes, 7 pacemakers, 4 retroperitoneal bleeds, 2 of which have required vascular surgical intervention, and we've had 1 death within 30 days. And again, a good result in terms of the hemodynamic result of getting rid of stenosis and not providing a leaky valve. So if you compare all of 2017 and 2018's data, the next few slides, as Rich has done, just shows how we compare to the UK reported data that was released last week. We have a 2.5% major vascular complication rate. We have a 2.5% stroke rate in hospital. Our in-hospital mortality is 1.6%. And our leakage rate for the two valves, so I'll report you in blue, we have for the Edwards balloon expandable valve, we have 0.5% moderate paravalve leak rate, and for the St Jude, now Abbott Portico valve, we have a 2% rate, both of which are below the BSIS reported UK data there. And we have no severe leaks. That's our pacemaker rate for the Edwards Sapien valve, the balloon expandable valve, 7.7%. That includes pre, pair, and post. And for the self-expanding valve, we're simply 9.8%. And in terms of when we get these people home, the UK mean is from the time of the TAVI procedure to discharge is 5.5 days. We're actually at 3.2 days. We say we aim for 48 hours, so at the minute we're getting 3.2 days mean for TAVI procedure to discharge. So these are our volumes up to the end of last week. So as you can see, we've had an increasing rate of volume, which really mirrors the UK trend that I'll show you shortly. The different colours represent the different access. So dark blue is essentially transfemoral, light blue is transapical, and the orange colour is transaortic. So this year we have been exclusively transfemoral. Richard's already shown you it mirrors what's been happening in the UK. And he's also shown you that we're bottom of the UK league table. Richard's also shown you this slide as well. I've just added to it slightly. So the UK is also in the second division of TAVI volumes per million population. The reason I put in yellow the colours for Germany, Switzerland and USA, in those countries TAVI has become the dominant mode of aortic valve intervention compared to surgical aortic valve intervention. I am told as of the summer, France is currently at 50-50, and by the end of the year, that bar will turn yellow as well. So this was the sort of next or final topic of my talk, constraints and challenges, and I'm a simple person. This is how I view the expansion of any service for that matter. We clearly identify demand, and I'm afraid Wales has a large demand driven by its population, the age and comorbidity of its population. We therefore need to drive capacity and resources to deliver that demand, and also therefore there needs to be a two-way dialogue between demand, capacity and commissioning to deliver this demand. So what I'll do, I'm just going to tell you a story. This is the story of TAVI over the last 10 years. So this is for Morriston. So we actually formed the team in 2008. We started in 2009. We stopped in 2009. This was told to be due to a combination of reasons. The honest answer is we never really got to the bottom of those reasons. It was told it was financial. However, we stopped. The Welsh Specialised Cardiac Services Review began in 2010, and for structural heart disease that was chaired by Richard and by APRIM. And as a result of that work, both centres restarted their TAVI programmes. We restarted in 2011. And we quickly began to realise that at the same time there was a wealth of randomised controlled data coming through to show the potential benefits of this. And we, in Morriston for Mid and South West Wales, began to get concerned about the rising demand, the limited resources, and the consequent long waits for the procedure. We requested to our executive that we actually collect data, as we've been describing throughout most of the disease states today, so we can actually record the data for wait times, procedure times, deaths on waiting lists for these patients, and that somewhat fell on deaf ears. In 2013, we simply had a meeting with the then medical director of WISC expressing concerns about the commissioning arrangements for TAVI in Wales. And in 2014, as I've just shown you, we began to really see a surge in demand, and that was following the publication of the main body of the randomised controlled trial data comparing TAVI versus surgical aortic valve replacement in high-risk patients, and I stress high-risk patients. We finally began collecting the data in 2015, but we'd already recognised that there were increasing numbers of people who were dying waiting for a procedure for TAVI. With the streamlining of the procedure, some of which I've outlined earlier, we began to increase our procedural volume, but we were still unable to keep up with demand. We were invited to a meeting with WISC last June. I remember it well. We were asked to present our waiting list issues, including the deaths on the waiting list, which we did, to which we were somewhat lambasted and accused of selecting patients differently. Within days of that meeting, we had a letter sent by Andrew Goodall to our CEO, which then came to us, which questioned our clinical decision-making, somewhat denying the demand. And in 2018, one of our colleagues finally undertook a review of the waiting list data that we've kind of been touching on earlier. So what I'm going to do, I've got 2 slides. I'm going to outline the process which is still ongoing. So Clive Weston very kindly looked at this time frame from the 1st of January 2015 to the 7th of December 2017. And he identified that in his methodology, he thought there were 50 deaths in patients who had occurred whilst they were waiting for a TAVI procedure. And obviously, because this is an elderly cohort, we know that these people don't always die of aortic stenosis. They have other comorbid illnesses that may cause their death. But Clive felt that up to 35 of those deaths were possibly or likely due to the aortic stenosis. The other thing he noted, the other headline figure, if you like, was the excessive wait times for these patients. These people were waiting way beyond a 26-week RTT pathway. I'll come back, there's one more slide which explains what we're doing now, and I will come back to that later. But should we really be surprised by deaths on the waiting list in patients with severe aortic stenosis? I'm hopefully going to convince you the answer to that is no. This was 5 years ago, this meeting, where Steve Dorman actually presented the deaths on the cardiac surgical waiting list. We've known since 1968, this is John Ross Jr.'s slide from the natural history of aortic stenosis. The plateau then cliff, as it's been described, which people fall off when they develop symptoms, has been well known. Median death within 2 years of presentation of symptoms, whether you present with chest pain, breathlessness or syncope. It's been well documented now for 50 years. We also know, and have known for many years, that if untreated, aortic stenosis has a dismal prognosis. If you look to the left of this slide, 5-year survival is less than 5%, which is worse than all of the commonly known and commonly thought of cancers. We've also known that you'll notice a very youthful looking Liam Penny on the right. This was, if you'll notice, I've ring the dates here, this was 2004. Deaths on surgical waiting lists. Let's fast forward to 2013 when Steve presented on behalf of the network the deaths on the waiting lists, which unfortunately made headline news. This is the WISC briefing paper from June 2013 for both Morriston and UHW, looking at the deaths of patients whilst on the waiting list for cardiac surgery at Morriston Hospital and UHW. This was Mark Ramsey's job as the Clinical Director of Regional Services to give his report on those deaths. And just to summarise, I'll ring you the salient sentence. These deaths are dominated by severe symptomatic aortic stenosis and confirms the adverse nature of this condition. This is Nav Masani's report from the UHW mortality. And again, I'll just ring this. 50% of the deaths were in patients awaiting aortic valve replacement. This is no surprise. We've been here before. The condition is malignant. Let's just fast forward now. What's the randomised data tell us for the TAVI population? Because admittedly, we've identified these people as being at higher risk, usually due to age and comorbidity. So this was modelling data performed by this Canadian group in Toronto, looking at the randomised trials, the partner trials of both TAVI versus medical therapy and TAVI versus open heart conventional surgery. And what I'll just show you, they've modelled on the left, the TAVI wait time and the risk of mortality on the right. And what I've circled, or oval, I guess I should call it, is that at 90 days, they've estimated there is an 11.8% risk of death at that level of wait time. That's for those people who are high risk, who are considered an equipoise between open heart surgery and TAVI. These are the TAVI group, their wait time. If you look at the inoperable group, in other words, a higher risk group combined, their estimated risk of dying within a 90-day wait time is 15.7%. Again, this reflects the malignant nature of the procedure. So, what are we doing? This is what is ongoing, and I stress it is still ongoing. So the ABMU executive has established 5 work streams. Firstly, dealing with the backlog, which I'll talk about shortly. Secondly, looking what a future service is going to look like to avoid getting into this state again. Thirdly, how we communicate with the relatives of patients who we feel have died whilst waiting for TAVI. Case reviews, taking a deeper dive into those cases where we feel these people have come to harm. And 5, a bit of a general look back to see how we've got into this state and how we can avoid it in the future. So just honing in a little bit on the case reviews, essentially Clive's review is being re-reviewed. The Royal College's of Physicians Invited Review Service has been asked to review the cases, the deaths on the waiting list. As of 2 weeks ago, I don't know the up-to-date situation within the last 2 weeks, but no contract had been signed with the RCP. I understand that was awaited. And clearly, once this review process of the deaths on the waiting list has been taken place, there is already a plan to contact the patient's relatives to take the communication with the patient's relatives forward. In terms of the plan for dealing with the backlog, we're now, as of 2.5 weeks ago, undertaking 3 TAVI lists a week in Morriston. 2 consultants, myself and Alex, solely working on TAVI, which means our colleagues are very kindly backfilling our, quotes, day job. We now have weekly executive and clinical operational meetings of TAVI, and you've heard about the weekly TAVI clinic and the weekly MDT. Now finally, I'm just going to come on to commissioning. This is the current commissioning policy for TAVI, and I'll highlight the dates. November 2012, this policy was written. It was due for review in 2014. This is the actual commissioning criteria. The pointer works. And I'll just draw you, this has been the huge bugbear for the clinicians working in this field within Wales, the so-called logistic Euroscore 20. It's a nonsense, an absolute nonsense. And we pointed this out to the then medical director in 2013, 5 years ago. It is also inconsistent with the rest of the UK. I'm afraid each patient has to have an individual funding request, as Rich has already alluded to, per patient. And I'm afraid those requests, or the decisions on those requests, take between days and weeks to come back. I've just told you that up to 50% of our inpatient activity takes up our TAVI activity. Waiting to hear weeks whether you can undertake a TAVI on an inpatient defies belief, in my opinion. So this is the new, improved version that we all started working on last December. You can see by March of this year, we'd already got to 6 versions of it. So it had already been round the houses for not just cardiologists, but cardiac surgeons in the whole of Wales, as well as Liverpool for North Wales as well. So this is already work that we started last December. This is still draft. I can't really see there's a good excuse why nearly a year on from starting this, we're still not able to implement and agree and put into place this policy. This is what it looks like. It looks remarkably similar. You'll notice that essentially the first bullet point is that the multidisciplinary team agree what should happen to the patient. That is consistent with the rest of the United Kingdom. The rest of it is pretty consistent with what we had before. But it really puts the onus on the multidisciplinary team to make the decisions about these people. My last hobby horse, before I get off my hobby horse, is the so-called idea of valve-in-valve TAVI. In other words, people who've already had an aortic valve replacement. Unfortunately, this is not commissioned at all by WISC, so we need to put in an IPFR exceptionality request to a panel that meets once a month. Again, not very good for your inpatients, I'm afraid. It typically takes 2 to 3 months to get a reply back. The comments I've received are, as you've seen in white, why can't you take the old valve out? I really did have that. Secondly, the NICE guidance you quoted is not relevant to valve-in-valve cases. The title of the NICE guidance is, in quotes, transcatheter valve-in-valve implantation for aortic biprosthetic valve dysfunction. So I was somewhat confused to hear it's not relevant. And last week, a patient of mine had a letter sent to her stating the reason why she's not been approved for funding for her valve-in-valve TAVI is because I filled the form in incorrectly. That's what's happening in the UK with increasing numbers of TAVI for aortic valve-in-valve bioprosthetic failure. I'm off my hobby horse, thank you.
Thanks, Steve. Richard, we'll have a panel discussion if you like. Shall we take a seat and we'll... First question.
So hi, it's Jenny here. I'd just like to correct the IPFR process. So I sit on these panels. If you need a decision, you can have that within 24 hours, and I have done several of those. We are perfectly able to convene an emergency panel, and we've done several of those. So I think we need to be really clear, and that's where the form is important, because if you indicate that you need a decision today, you can get a decision today. So I accept that may not be... I'm just explaining what the process is. So, so everybody in the room is clear.
I'm explaining what the reality is. We will put, if the patients are an inpatient, then I will put in bold type, this patient is an inpatient. I tick the box on the form which says that we want an urgent response, with it, which in your box is 24 to 48 hours on the form.
Fine, so I think it would be helpful.
I'm only reporting as the end receiver what we receive in terms of the timeliness of the response.
So I will take that very seriously, because if we are doing a patient a disservice, then we do not want to do that. So it might be useful to review the timescale of some of those requests and see, because if the process isn't fit for purpose, we'll look at it. But that isn't my experience. So. Well,
I'm afraid that is my experience.
Yeah, that's fine. So we'll look at it. We'll take that very seriously and have a look at it and feed back to the network in terms of what the reality is from WISC's perspective as well.
And the other point to make to that is that comment has been made year on year since 2013. Okay, we first raised this whole process of the not fit for process IPFR system with Geoffrey Carroll back in 2013. So and the agreement, which I'm happily send you the documentation for that, was that there was an agreement that this process is not fit for purpose.
So the IPFR process is a process that is agreed through the Joint Committee. They run WISC. WISC is not an autonomous entity. So if the chief execs of all the health boards that are providers and commissioners have agreed that process, I will take this really seriously and take it through to our quality and safety committee, because we can't be at an impasse with something that is this important. If we have a process, I'm quite happy to review it and quite happy to look and share what the reality of that process is, because that's a huge concern to me. and as it is to you, clearly.
I think we can also say, if clinicians have individual problems with anything like this, please just pick up the phone to myself or to Jenny, and we will get it sorted.
Can I just make a comment on the valve in valve? Because I'm a bit surprised by that, because all of mine have been approved. And the only reason is because I'm assuming, I put on obviously the form, or the new form now, that the logistic use score is over 20%, and then I attached the clinic letter and the MDT. Now I'm assuming somebody reads that, and if they need a valve in valve, for example, one of Nigel's recently, in September, there was no comment about it being a valve in valve, it was just approved. So my point being, there is discrepancy in this process from the get-go, and that's my big, well, that's apart from filling the forms in, that's my second big bugbear about it.
Can you say about the process, that if it was a clinical thing in a hospital, you wouldn't send a form. You could send a form, but you'd always pick up the phone and speak to somebody to make sure there was going to be a decision. Yeah. It's going to be, yeah.
So, both sides need to talk and explain it in the scenario, so that we can decide how best to spend public money.
Which is where all of us came to the point was, could there be a hotline? Is there a number that goes with the form for these sort of patients?
Whose number is on the form can always get hold of us. I'm more than happy for you to have a number if that makes assures you, but that's the process.
Well, I phoned up Kathy Dew last Friday, and I was passed to Professor Dool to speak to, and Professor Dool was unavailable, and I'm still waiting for the call back. But the point is, the process itself is not fit for purpose. When we have up to 50% of our patients, and Richard had about a third of his patients are inpatients, this process is not fit for purpose.
And I think that's why we have tried to, revise the policy, and we're trying to get it through the various processes it's got to go through. But WISC has to get stuff approved by the health boards, and we have been waiting for things like plans from the units as to how they're going to deal with the capacity and things like that. So it is working through. You have our commitment that this is something we want to see the back of as well, the IPFR process. Our commitment is to get rid of that and get the new policy in place as soon as possible. I'm conscious that some of the colleagues in North Wales may have missed out on up to half of that last conversation, but are there any comments from North Wales on this particular issue?
No, we don't have any consultant cardiologists in the room here, so we're admiring the sidelines, excellent presentations, no questions from here.
Okay, right.
Sorry, can I just make a point? I agree it's not fit for purpose, but in terms of support for WISC and Jenny, because they invariably don't get support, I submitted a request form on Tuesday morning, and I got an answer within 2 hours. So if you chase it and it's an urgent request, you can get a response from WISC.
I'm sorry, but am I missing something here? This is a proven treatment that works for these patients. Why can't we just do it? Why do we have to go through this process? Okay, if it's a difficult patient, if it's new technology, this isn't new technology. It's been around for 8, 9, 10 years. So surely this should be part of our standard process of patients that go through an MDT, proper clinical, with all the right people there. Then they say, this patient needs open surgery. You don't have to go through this process for open surgery. But they need a TAVI, they have to go through this process. It seems ridiculous to me when it's standard treatment. Why don't we just say, let's? MDT says, yes, go for it. Why don't we just do it for the patient's benefit?
I think the reason it's there is related to events that went on in before, where there was concern about having a real feel for what was happening with TAVI from WISC's perspective. We agree that its time is probably done, and we expect to be able to do it very soon, within the next few months. Any other questions on?
Coming back to the MDT process itself, I was encouraged by the fact that you're almost making sort of care of the elderly review. I have some concerns about the MDT process. That Richard's slide, your initial slide. Generally, MDT
think your mic's gone off. Have you accidentally pressed the button?
Sorry, the MDT process, I feel much more comfortable having it routine that you have an assessment by care of the elderly, etc. Because otherwise, it seems to me the MDT process, generally, I don't know it's national guidance, but the MDT process is driven predominantly by people who do rather than don't, and in the context of what John was talking about before lunch.
Yeah, I think you're right, Adrian, because when you see anyone, you know, are they going to, do they have a life expectancy of 2 years? That's in the commissioning guidance. So that's number one question. And actually, two, are they going to get better? Because otherwise, there's no point in doing it. So, you know, and I've had really young patients, I've just done that because even if you replace their valve and you say, I can just magically do that now, they will get no benefit in terms of their overall quality of life. So there are some tough decisions to be made sometimes. So those are the key metrics that I use before I even think about asking anyone to see it, anyone else to see them. And that means a cardiac surgeon as well. And those who I'm not quite sure about, then that's when time to phone a friend and ask someone else to see them. And we're lucky with Dr. Sim, who will see them and assess them and give me a person who sees these type of patients on a daily basis. Is there going to be actually value to you doing X to get their overall patient body better for them to live longer? And that's sometimes not an easy decision. So that you're right, sometimes you do need a lot of care of the elderly input.
Which I thought you actually did a study on this where you took 100 consecutive patients and got Dr. Sim's opinion, and then it was blinded to whether it would agree with what the MDT came with or without him, and there was no difference in the decision. Is that not right? That's what Peter said at the last joint meeting.
He gives very good feedback, and it's often lots of things that you don't quite appreciate with some of these elderly patients, all their sort of bladder medication, you know, to give them better bladder stability and things like this, you know, that can actually have, you know, so lots of, they have good input to get the patient slightly better, sometimes for the TAVI. Sometimes he says TAVI is the only way that they're going to get better, and sometimes he says, I think they're too frail. So I think for the patient it's better.
Peter said it was a specific study whether inclusion formally of a geriatrician at every decision made a difference to the outcome, and the outcome of it was not. That's what I understood what Peter Groves told me. It was the study that was done last time we met.
No, I don't think it was.
And that was in that room at the meeting that Dave talks about in June.
There was the study looking at all the various frailty measures. No one performed better than the
others.
MDT.
Yeah.
Was the outcome of that. I don't think anybody would say that having a care of the elderly physician isn't helpful, but a lot of times their decision was in keeping with the MDT, and no test, whatever the test was, outperformed the MDT.
I think also...
Yeah, a specific frailty test.
I think also we all need to be, to a degree, a filter for these patients. We've known historically that most people with aortic stenosis who go back 15 years didn't get referred. We were discussing this yesterday, that actually we all see people with aortic stenosis a little bit like heart failure, isn't it? We all see people in our daily practice with heart failure. It doesn't mean to say we refer all of them for devices. So in some degree, we're all of us got a certain degree of responsibility into who we actually refer on for potential intervention and those that we don't, because clearly this is a filtering process. By the time someone gets to see us in the TAVI clinic, they've already gone through a number of filters, primary care into secondary care, and whoever's seen them in secondary care into tertiary care. I don't disagree with you. Who the best person is to review these, as I alluded to, I think is different from patient to patient. As Richard's pointed out in his data, up to half of his patients have got lung disease. So I don't think those are necessarily best seen by a geriatrician. I would want my respiratory colleagues to give their opinion on the severity of their lung disease. So there needs to be a little bit of an individualised process, but I do agree with you that just because you've got aortic stenosis doesn't mean you get a valve, be that TAVI or surgical, and there needs to be an overall appraisal of the patient and their specific clinical characteristics. Well, that's partly the point I was going to make, was that surely a lot of this responsibility is with the secondary care cardiologist, who can get a chest physician, because obviously you have lots of discussions with my chest physician colleagues who've got severe COPD, they've happened to pick up aortic stenosis. The question is, if you replace their valve, are they going to be any less breathless? A lot of the time, they're not. So why are we doing it? Their symptoms, it's different if they've got angina or they're having effort syncope, but a lot of them, it's just breathlessness. And I think there's a responsibility as secondary care cardiologists to do some of the filtering, so you get ones that really there's a decision that has to be made, and then your decision has to be made whether they are fit possibly for open surgery, or whether you're actually going to do TAVI, or you say, look, actually their risks are too high, they've got this wrong with their aorta, they've got this wrong with their annulus, they can't have it for whatever reason.
And that's one of the reasons why we got so upset with the logistic Euroscore issue, because that doesn't take into account virtually all of those variables. So I agree with you, at all stages there needs to be a sort of a more holistic overall assessment of these patients. What we don't want, certainly don't want patients dying because of aortic stenosis, but what we don't want to do is put new valves in people who are dying not because of aortic stenosis, and that's where the art of medicine comes in, as opposed to the science of medicine, if you like.
One of the things we talked about when we were putting together the new policy was about which investigations should patients have beforehand, and where should they have them? And I think we parked that one for service specification house because it was rather difficult. We were in about 8 different flavours of what people thought. But can I ask your views?
I think what we were aiming to achieve, and I think it was a laudable aim, it was just that we got bogged down in the sort of the different menus, I guess, really, didn't we? That the idea of, again, I suppose, shared responsibility between workup, as we've been discussing earlier, as Nigel raised the point of with Richard earlier, shared responsibility for the workup, because what we're really aiming for, in my opinion, for these people, once we make a decision to treat them, what we don't want to do is delay their treatment, because we're doing a myriad of investigations. So what we tried to do in the document was set out what we called a minimum diagnostic criteria to allow a referral into a TAVI clinic, and really that should be the same for a surgical aortic valve consult as well. So I'm very much for the fact that I think there should be a minimum diagnostic workup that we agree upon and insist before a patient gets seen, because ultimately what I've shown from the waiting data, unfortunately the outcomes of aortic stenosis are time mediated. If we do wait a long time, we know what we're going to get. Personally, I think, and we've suggested this, that severe high-risk aortic stenosis, if I can call it that, should almost be considered along the lines of urgent suspected cancer in terms of waiting time, because we know from the data that the longer we wait and the longer we wait to work these patients up, the worse their outcome is going to be. So I'm very much for, and I think this probably needs to be done on a regional level per centre, agreed minimum diagnostic criteria to enter the TAVI review service and then go forward for TAVI. But as I said, because of the discrepancy we have between Liverpool, Swansea, Cardiff, I think that's going to be centre-led.
Do you think that could be an aortic stenosis pathway rather than necessarily a TAVI or surgical?
I think it should be an aortic stenosis pathway, because I don't really see any reason we should be discriminating between the modality of treatment when it is the disease state that drives the outcome.
Oh, it's got hands going.
I've got the mic.
Hello. you got it first. Go for it.
You've got to talk into it.
I just, when our colleagues said there's no colleagues from North Wales listening, I just wondered from a WIS perspective, have you not invited them to present their Liverpool experience of TAVI? And might that be because they don't have IPFRs, they don't have a waiting list, and they're a one-stop shop clinic with a CT on the same day? Was there any deliberate intent not to invite them, or was just no one free to come?
This is a cardiac network day, not WISC day, so I didn't do the programme. No idea.
So nothing to hide.
So just hang on, Andrea, so we can get back to you.
I can answer the question. In regards to Liverpool Heart and Chest, they also complete the prior approval forms for patients from North Wales going into Liverpool Heart and Chest. They have the same
But not for their
process.
English patients. That's the point.
No, our Welsh patients that go into Liverpool Heart and Chest have to fill. It's the same referral pathway for North Wales and Liverpool Heart and Chest.
But they do have a...
Yes, we know.
You're correct. They do have a different process for each, although they also have a limitation from their commissioners as to how many cases they can do in a calendar year. So their constraint is different. It's for their English patients, but there's a constraint nonetheless there.
It'd just be nice to hear it described.
Yes, I mean, they're having part of the guideline, the policy development.
Quick question to Whisk. The new policy, which is awaited, brings us in line, I think, with the rest of the UK.
Yes.
Yeah.
Will that do away with the majority of the IPFR?
Yes. IPFR is, for anything that falls within the policy, IPFR is not required. It will be for exceptional.
I would reinforce then what Dave said, that the way to commission this, and I think that is the plan, is to commission it as aortic stenosis pathway. Because the interventions for aortic stenosis in the new world have changed.
Yeah,
we need to recognise it and say, well, it's an aortic stenosis pathway. There are at least 2 interventions.
That is our plan, but rather than delay this one for a while, we're going to we've started work on the aortic stenosis one. Aprim.
I think the last point you mentioned is very, very important point. The point of pathway for aortic stenosis rather than TAVI. I raise this point because quite often the referral comes for consideration of TAVI. The patient has already been told they will have TAVI. And when they come to the consultant surgeons, we look at them, they are very suitable for conventional surgery. And it becomes very difficult for us to convince that patient that this is a better option for you. So I think my pledge to the colleagues referring these patients, refer them for surgical intervention or for intervention for severe aortic stenosis, and the MDT will make that decision. So I think this is a very important point, because quite often the referral says consideration of TAVI, severe pulmonary COPD, then you look at their figures, FEV1 of 58%, 60%, where we do lung resection for. That's not severe COPD. So I think it's very important to leave those decisions to the MDT. So just refer them for intervention for severe aortic stenosis. And then the cardiologists and the surgeons who are on the MDT will make that decision.
Thank you. Next to you, Pankaj.
There are 2 or 3 points I'd like to make, actually. I mean, I agree with everything that has been said. The mortality is high, and so on and so forth. So we're not going to go over that. The second point that I want to make is that remember the data that has been shown for intervention for TAVI, for aortic stenosis. The average age is 80 to 82 for the 2 respective centres, as is the rest of the UK. Now, for an average 80-year-old in the UK, the annualized mortality is between 7.5 and 8.5%. So we mustn't lose the perspective here as well. That's the first point, to give you a background of the population demography. Secondly, even after aortic valve intervention, whether it's surgery or TAVI, the risk to go back to a age-matched population of mortality is not realized for 6 to 12 months afterwards. So the sooner we recognize them, the sooner they're treated, if we really want to reduce the risk to an age-matched mortality, the better the results would be. There is no point in having a protracted pathway and then taking another 6 to 12 months to get back onto that sort of survival curve, so to speak. So I think I totally agree that I think the pathway needs to be a single pathway for high-risk aortic valve intervention. We can call it whatever. It should be intervention. Patients shouldn't be coming into the outpatients clinic to see a cardiologist or surgeon saying, well, I'm going to have this TAVI, Mr. Kumar, because it is just impossible to retrieve the situation from that point.
Thank you. Okay, we've overrun a little bit. Well, that's been a very valuable discussion there. So can I ask you to grab a cup of coffee quickly, and we will reconvene at 3:30 as we planned originally.
How long is this sort of something also, you know? What does she do with that? Does she always go down there?
Yeah, she'll come down because she'll go right in.
She's happy to do that. Oh gosh, yeah. That's a television.
And then on the sunny day sometimes then she'll go. But at the moment I'm just trying to get her
Will she do it down there? See, because Roger's the same age. He's running all the way with that. So we ended up getting He's quite conscientious, and I don't want to say so
hasn't been until I've had a few exams
She year 10. She's just done the mathematics now.
So she's done the reality was a little bit, oh my god, this is it.
Yeah. It's about now, because it's from now to 25.
But then what I'm trying to do is
we've been a bit liberal too about, because we scams, about saying we'll come down and we'll bring you back, and we've got one. I am one of the meetings last week. It wasn't a terrible mess. It was some influence, and that made me down. And some influence, and the patients sort of did this, because the water was off. I think Sue was telling me something like 20, 30 pounds for because what's the name? The guy that plays he just spent January and he never got to ours, so we've been running on this 4 minute leads, and I'm now we've got extension going up. Every 5 minutes. It's yesterday the garbage empty this weekend. The garbage for the crap.
No, Alex
yeah, we're pretty good at that. Boys were quite pushy, and we used to just have going to sweat since his birthday. He used to join the so it's kind of we're all quite different. We're good at next folks. We're good at wetsuits. Yeah. You know, and he knows that. He knows that kind of stuff.
And Alex has just
How long is he going for?
and it's available on the network website, as is published today the NC pod review into heart failure, and that's on the website. Regarding this meeting, you'll have an email after the meeting asking for your feedback, and if you provide the feedback, you get your CPD points. So there's a lot of people laughing, I'm not going to get any CPD points, I guess. And finally, a bit of housekeeping is about parking. If you've parked over in which direction, Pierhead car park, then if you go to reception on the way out, you'll get a ticket which allows you to have £6 for your parking fee. Okay. Right, I'll start then. So the Atlas of Variation. Thank you. So what is it, I suppose, and why are we doing it? This is one of the reasons why. So we've had excellent progress, haven't we, in reducing the incidence of cardiovascular disease through research innovation, drug and technology development, and increased investment in cardiac services. But the prevalence of cardiovascular disease is increasing precisely because we've decreased mortality and the population's aging. So it's a big problem, and it's the cause of the major problems we face. I think we all recognize this. There's a gap opening up now between need and demand for healthcare on one hand, and our resources on the other. It's partly due to the successes we've had in the last 2 decades. And also, we've got this thing called unwarranted variation, which is a variation that cannot be explained by the patient's needs or the patient's preferences. And I'm going to spend a bit of time talking about unwarranted variation, because it's basically a waste. So in cardiovascular care, it may reflect the differences in investment in your cardiac service. You may not have something, you may not have enough of something. It could be the delivery of diagnostic and treatment interventions, and it can be variation in patient outcomes, or a combination of any of those three. So underuse of the high-value interventions are often compounded by inequity, because it's inverse care law. Those who are at greatest need sometimes are the most disadvantaged groups in the population, and they have the poorest access. And we have overuse of low-value interventions. For example, providing a treatment of limited value, or providing treatment to people only mildly affected and will therefore get very little benefit, but it costs money. So unwarranted variation is one of the major wastes in healthcare delivery. So it is defined there by John Wenberg. It's quoted a lot, but it's variation in health delivery that cannot be explained on the basis of the illness, the medical evidence, or the patient's preference. What we're trying to do is look at the whole system, look at the efficiency of the system, the cost, the quality, the patient experience, and then somewhere along that, you've got to have some scrutiny put in. So this is why we set out to develop this cardiovascular atlas of variation. Our delivery plan, which was agreed, demonstrated and pointed out that unwarranted variation in the practice and delivery of the service was one of the key remaining challenges in delivery of cardiac care in Wales. It's been very difficult to establish good comparators with benchmarking and clinical audit, and it's been difficult to maintain those when they have been established. So the aims there of the atlas was to firstly try and identify unwanted variation, and to investigate the reasons for unwarranted variation, whether it's due to overuse or underuse, or both, and then use it as a tool to effect change. So if you recall, I think it was spring this year, in the Cardiovascular Society meeting, Samira Gray came and spoke from Better Value Healthcare, and he talked at length, really, and very well about unwarranted variation. And we had done a proof of concept for the atlas. So taking readily available data, we hadn't gone out and collected new data, this was available data, and mapped it according to, does that project? Not too well, I'm sorry, it's not brilliantly projecting. What the map does, it's cut into GP cluster areas, and the map is showing emergency admissions to hospital for people with heart failure, and it's normalized per 100,000 population. But what it really shows, different colors means different rates, which shows variation. Doesn't give you an answer, doesn't give you a cause and effect, just shows variation. And if you look at South Wales, there's a clustering of dark blues, bottom right-hand corner, and in the middle of those clustering of dark blues, there's a almost white area. So immediately you think, why? So what we will do, this is rough and ready data, it's not the data we want to present to you ultimately. What we would be asking is, why is that variation occurring? We will be looking at deprivation scores and age and everything else and putting all that in. But that's the whole point of these maps, is to say, why is there variation? What does good look like? Is good the low rates of admissions? Or is presumably yes. Therefore, if that's what good looks like, let's go into those clusters and say, what are they doing well compared to the clusters where there are high rates of admissions? So it's a way, it's a stimulus, if you like, it's a disruptor. Starts you thinking about pathways. And what we've done with the Atlas is to look at a pathway from the beginning to the end. So we started it at prevention level. So we got the observatory have done the risk factors and done the Atlas on the risk factors. We're looking at, for heart failure, admission rates for acute heart failure. We're looking at length of stay for heart failure patients. And we're looking at readmission rates at 30 days as the indicators. And the indicators we're using have been agreed with our expert reference groups in the Cardiovascular Society. And for the Atlas, we focused on the three main things that the network have put in the Heart Conditions Implementation Plan, which are heart failure, AF, and ACS. Now, the plan initially was to publish this Atlas in December, but there's been some delay in getting some of the data and also quality assuring the data, so the publication date has been pushed back probably to February. I'm looking at Michael Thomas, who's given me the nod, that's right. But we want to make sure that the data that goes in is quality assured, so anything we show you as professionals, and this is meant for you as professionals, the multidisciplinary team, the commissioners, your AMs, your counsellors, primary care, everybody should be able to look at these maps, and with it will be a commentary, which will be one page, explaining what's on the map, and giving some recommendations based on what we think might be going on. So in this case, there's a more than threefold variation in the admission rates for heart failure, and some of the potential reasons, as I said, just quick and dirty, are down on the left-hand side. So it could be, I'll just pick a couple, it could be one of the issues for the significant variation could be the access to diagnostic tests. It could be access to the rehabilitation programs in the community for heart failure, or level of care support in the community. So that's how we'll use it, but the problem is, as you'll see, once you start thinking about it, you basically have that. You've got a can of worms. You don't know what you've got, really. But that's what it's for. It's to start the conversation going and to start thinking about pathways. And we've had advice from Better Value Healthcare, and they've developed something like 10 atlases now for England. There are a lot of experience. And what they've said about the atlas in Wales is the only one that's actually taken a pathway approach from risk factors through to various stages of a pathway. So I think they're quite excited by the concept. It's whether we can deliver on that. What? Oh, we've already done. So brings me on to value-based healthcare. So we're all, I think, pretty familiar with the paradigms of evidence-based care and high-quality, safe, effective care. And the new paradigm is value-based care. And it does encompass both of those, but it's slightly broader scope. So it's a so what with these atlases, and the so what is, in order to see unwanted variation, how do we find funds to move funds through our system. So how do we find funds to invest in innovation or to meet the unmet need we've exposed? You've firstly got to find or identify the cases where you've got overuse. And that's value-based healthcare. It's got 3 dimensions, one related to the individual and the others to the population. So personal value is really determined how well the outcome relates to the values of each individual. So what does the patient get from having this done? Is there a good outcome for the patient? That's what they would value. If I've got a bad hip and I can't walk and I have a hip replacement, great, I'm back to normal. In fact, I think hip replacement was voted to be the most valuable intervention in medicine recently. Allocative value is how well all the assets are distributed to the different subgroups in the population, and the technical value is how well those resources are used for the benefits of all the people in the population. But this is the bit we need to remember, that we, the doctors, are spending the money. It's us, we spend the money, not the managers. Okay? I know we sometimes think we can't do things because of this or that, but actually we spend the money. And as a result, we ought to be accountable and responsible for the use of the resource. And as doctors, we should be in the rooms looking at the whole pathway, deciding, is that the best way to allocate funds? Is that the best thing to do? I don't think we understand how much power we have, and I really don't worry about the fact you won't be engaged in this, because just about everybody in this room wants to do a better job. Everybody are involved in these pathways. And I'm pretty certain you will get involved because the history is there. You've all tried. You've had several presentations about how you've taken a problem, turned it around. Yes, we do need managers on board, but they don't usually stop you from doing things. So this is the bit of history, but self-directed medicine was, this is how I was taught, this is how I do it. Thank God we don't do it like that anymore, but we moved on to evidence-based, and the evolution is into what's been called here right care. So it's evidence-based practice with one eye on the cost and unwarranted variation. And then the final evolution is to sharing the decision-making, the costs and everything else with the patients. So co-production, if you like. I put this in to remind me to say thank you to everybody who's worked so far in developing the care pathways for AF, for heart failure and for ACS, and for contributing to the development of the Atlas by narrowing down the indicators that we're going to put in the Atlas. And this is a journey, a patient journey sort of model. And the reason I'm putting it up is because we need to start working on care pathways. So we'd all recognize this in a hospital anyway. There's an admission, there's some diagnostics, there's treatment, and a discharge home, then a follow-up. But underneath there are all the people involved so the doctors, nurses, pharmacists, the cardiac physiologists, the patients, the admin and support staff, and the allied health professionals, the OTs, the physios, social workers. They're all important, but if we're talking going forward into developing proper care pathways, they all need to be in the room. And we need to develop standards of care for our pathways. And the way I'm proposing we do it is to develop the standards of care with our multidisciplinary team. It's doctor-led, but it includes patients. We then devise and design a visual model of the pathways so that patients can see where they are likely to be going. It's communication, basically. And then you can educate the patients on where they are on the care plan. It's well established. I'm not making it up. It's just well established. It's common sense. So we start with that. And the idea is, with that, from the heart failure thing, we've got a pathway, and we've got an atlas which maps a pathway from prevention to early diagnosis to optimizing interventions and end-of-life care, ultimately. So we look a bit like this. From the prevention side, we've got the cardiovascular risk factors, and Mark's in the audience been working with Public Health and the Observatory to develop the risk factor atlas. We've got the early diagnosis, symptom recognition in primary care, availability of BMP testing and use of, and echocardiography, again, as per NICE guidance, 2 weeks for urgent, 6 weeks for routine. As we all know, the issue we have at the moment, it's an 8-week target, all told. So there's work to do with that. The interventions, medicine, titration, monitoring, community nurse, specialists, and tail end of the pathway devices. And then things like at home for support, palliative care, parenteral diuretics, and then advanced planning in a preferred place of care. Because a lot of the heart failure patients come to hospital to die, but they don't want to be in hospital to die, and we wouldn't want that either, would we? So it's working our pathway from top to bottom. So just to reiterate, my very last slide, the aims of the Atlas are many and varied, I suppose, but the main aims are, firstly, can we identify areas of unwarranted variation? And then can we investigate the reasons? Basically, can we define what does good look like? And can we then replicate what good looks like across the population? And can we use the Atlas as the tool, as the disruptor to engender some culture change and move towards this value-based healthcare? So I think it is my last slide. Yeah. Thank you. I promise that when we've got Atlas, we'll come back with some data. So any questions? Stunned. Any questions in North Wales? Anything up there, Graham?
A couple of comments, I think. Thanks very much for the talk. In terms of looking at the determinants of health that are affecting cardiovascular risk factors, I suppose we know that it's the economy stupid, to coin a phrase, that socioeconomic deprivation is associated with double your risk of cardiovascular disease. Obviously, as health professionals, we're limited in how we can impact the economic determinants of health. But I suppose we can compensate to that to a degree by concentrating our resources on the areas where we know there's going to be deprivation. I suppose that's my main point, but also in terms of the process of care, we know there's difficulties in access to GP services. They're becoming increasingly nurse-led. So having a doctor-centred view is going to be limiting us a bit. And certainly from a primary care perspective, I'm speaking as a GP now, we think that over 90% of cardiovascular care is undertaken in the community or GP setting. We're doing that with less than 10% of the NHS resources. So we feel there's a great imbalance really of what we're doing in terms of hypertension management, cardiovascular disease management, the AF, heart failure, ischemic heart disease, everything we've listed. So that there is a balancing process, I think, that needs to be undertaken as part of this, the value-based healthcare. So observations really rather than questions.
Well, no, if I the relevant observations, I should clarify that the Atlas is looking closely at socio-economic factors, and we'll be looking at all of that, but also some of the risk factors and some of the disease. We probably will be looking at doing some scatter plots to look at socioeconomic deprivation and incidence of disease. The second thing is not doctor, what did I say? It's not doctor-centered is what you said, it's doctor-led in terms of the multidisciplinary team who developed the pathway. It's just doctor-led, it's not doctor-centered, it's patient-centered. And in the room would be all members of the MDT plus patient representation. And if anything, patient representation has been the most difficult thing to deliver. I'm just scanning our audience to see if Joe is still here from BHF. But BHF have a resource we can tap into. The Royal College of GPs have a resource we can tap into. But we do need patient representation. So your points I take, but I will also push back and say the socio-economic stuff is really central to the Atlas.
Just a comment I'd make as well. I mean, delighted to see this morning's presentations. Highlighted variations that we're seeing, all sorts of things, and so work that will help to deal with that is definitely valuable. We're looking at WISC at value-based commissioning, and really we need the ideas and concepts from yourselves in terms of where we can create value within the commissioning process that can help us to put in place better quality care. There's no more questions. I'll hand over to Phil then to summarise the lectures.
Okay, I will be quick. Hopefully it's not going to take me nearly 2 hours to get back to West Wales as it took me to get here this morning, so hopefully not. Hopefully we might beat the traffic, who knows. I'd like to thank everybody that's come today. I'd like to thank you particularly who are still here, who's lasted the day. You should get a medal. Thank you for all your contributions, and thank you very much to all the speakers. I think we've had quite a lively debate. I think what I'd like to do is draw a few things that perhaps we need to have some actual concrete action points, and we need this discussion with the network, with WISC, and I think also with the individual health boards as well. I think they need to be involved in this. They need to know their role in dealing with cardiovascular disease rather than bouncing it backwards and forwards between, oh, well, clinicians do it locally, or we'll get WISC to do this. We need actually everybody on board. If I go to this morning's first discussion about ACS STEMI, I think a number of things that came through that we could invest in to actually at a low cost but high value, to quote John, is an ambulance to actually deal with these patients, to get them to where they need to be at an optimal time. Whether that is also investing in treat and return, I think that's very important. We can do that. Clearly, we've got equipment that needs commissioning and we need to use, because we've got the need, and we know that intervention of these patients, certainly timely intervention, saves lives, improves morbidity and mortality. I don't think we can argue with that, and we can do that. We also, I think, need to be going back and actually doing some education, and I think probably people like myself are very much responsible for that, and making sure that because not everybody with ACS is seen by a cardiologist, as we clearly learned this morning, that we make sure that our emergency departments, acute physicians, general physicians, also know what the pathway is, know how to deal with patients, what patients are high risk that need to be referred early, and make sure that the actual methodology referral works and happens again optimally. So the patients get the cardiac centres or the intervention centres know there's a patient there that needs to be done as soon as possible. Sometimes a lot of the delays are that nobody knows this patient's sitting there in a DGH with unstable angina or what have you. So I think there are a few things there that we could easily do. So the final thing in that, I think, is we really have to look at ring-fencing a day facility or facility where these patients can go to, have a treat and return with the ambulance, so that that is not used for general medical patients. Otherwise, we are wasting a resource. If you've got, you don't want a situation where you've got an empty lab with patients sitting in DGHs and nowhere to put them. We've got to actually have some way to do that. So those are a few simple, concrete things we can do, very simple to sort that out. We've talked about surgery, and I think one of the most important things is that I think we are, to some extent, deluding ourselves into actually what the referral treatment time is. There are lots of little gaps and little grey areas and patients sort of in limbo that don't quite get counted properly. So we need to have a system whereby we know we can actually track the patient across different health boards, across even different hospitals within health boards, which we're not doing at the moment, to know what patients are there. We need to have clear guidance as what patients need before they get referred as inpatients to the surgical teams. And that's obviously, a lot of it can be diagnostics, what they need in terms of whether they need a chest opinion, do they need cardiology opinion, do they need urology opinion, for goodness sake. All that can be done locally. So the patient is a nicely wrapped up package that can be done, and the surgeon can do what the surgeon does best, is fix their heart. So the other issue with surgery is obviously staffing, in terms of actually staffing the theatres. Now, that's clearly a slightly harder one to address, but we need to be looking at ways we can attract staff, retain staff,
there may be some things we can look at in terms of that. Come to this afternoon, I think the TAVI discussion was interesting. And clearly, we can't be dragging our heels in a proven, cost-effective intervention trying to go back 8 years to what it was when it started. That's true of so many things we've done now. And I think we have to think in terms of an aortic stenosis pathway. We've seen that it has a high attrition rate, and we cannot run away from the fact that aortic stenosis, there's an epidemic of aortic stenosis now. We've got aging populations that we're keeping alive from various other things. They're now getting aortic stenosis, and we can't avoid that. We need to treat them. We have good treatments, both surgery and by TAVI. So I think the one thing that's come out of this, we need one aortic stenosis pathway that goes through the chiropractic surgeons, as Apple was saying earlier, that's the way to go forward, and then the decisions can be made. But within that, again, we need that data set. What do people like me need to put in place, have done, got ready to send them into that pathway, so that they are, again, tied up in a neat bundle, so that they can be then discussed at an MDT and have their operation, whether it be TAVI, whether it be conventional aortic valve replacement, it doesn't matter. It's one disease, should be one pathway. So I think those are the things I think I've taken out of that, and we will certainly need to be having discussions with that within the network, with WISC, and obviously I think the health boards need to be put on some pressure. Maybe one of those things is the component end-to-end weights that we need to perhaps harden up and get them to do. I think the atlas of variation, okay, John's briefly gone through the background. I do think it's going to see where that variation is, where things are right or are very good, and we then need to share that practice. I think, again, both as GP clusters, as DGHs, as regional centres, as regions, we do tend to work in splendid isolation. And I think what we need to do is have that more regional approach, more cohesive approach to patients with cardiovascular disease, because what we really want to aim for is for the patient in Aberystwyth to have exactly the same treatment for their cardiovascular disease as they do in Cardiff. And that's what we need to be achieving, and that's what the variation will show us, and what we can do to try and improve things. I think we need to then work together to try and achieve that. So I've been quick. Oh, look at that. 4 o'clock. Okay, so again, thank you very much for coming. So don't forget about your ticket if you parked in the Pierhead car park. You can get it because I've got mine in my pocket, so I'm going to do that. And as I say, thank you all very much for coming. And I would like to thank, who's not here, Zahir Youssef, who did a lot of work to put this together. And apparently I owe him a lot of beers for all the work he put into this. Thank you very much for coming. Okay.
Very good day. Are you pleased with it?
Yes.
Good.
Relieved.
Did well. Well done.
Awake at 5 o'clock.
Oh, you always fit.
I know, but
it's good. I mean, you've done everything you could.
Yeah.
If anything had gone wrong, it's outside your control. Exactly. Do we need to collect caps and clear up for them?